This meeting is being recorded.
Good morning. It's a beautiful Saturday.
This meeting is being recorded.
Today we'll be discussing anterior segment complications of cataract surgery. Good morning, everyone. Today we'll be discussing anterior segment complications of cataract surgery. As we know that cataract is the commonest cause of avoidable blindness worldwide. Luckily, cataract surgery is also a way of life restored, making it procedure performed in ophthalmology. Be that as it may, like any other procedure, it has its own complications. And to discuss the anterior segment complications of this surgery this morning is Dr. Abiola Lawal, Senior Registrar from the Eye Foundation group of hospitals. He's a young ophthalmologist and should be discussing this. Thank you very much, Dr. Abiola. You can go ahead. Dr. Abiola, can you hear me?
Yes, good morning, everyone. I don't know what happened to my slide. Sorry, I think my slide.
Okay, can you share your slides?
Can you still my slide?
No, please.
Okay.
Can you share screen again?
Yes, that's what I'm trying to do now. Okay, can you see it now?
Yes.
Can you
Yes,
see my
please.
slide now?
Can you make it slide share?
Okay. I didn't get that. Can you see my slide now? I'm sharing. Okay, so I can proceed.
Yes, Dr. Abiola, you can see your slides. Make it
Okay.
make it slide share. Can you put it on slide share?
Yeah, I tried that. I think it's I tried that with Dr. Baturi. It's just not working. So
Earlier.
I think we should, yes. So we'll just
okay. So
okay. Can you see?
Go ahead.
Just we'll just make do with what we can see right now. Okay. Thank you, Dr. Nurat.
Yes.
Thank you for
clearly.
asking. Yes. Okay. So you gave a very good brief introduction. Cataract, we all know, is the opacification of the crystalline lens, and cataract surgery is the most common surgical procedure globally. And the most frequently performed ophthalmic procedure is cataract surgery. And that is quite understandable based on the burden of blindness from cataract. Over 43 million people are blind from cataract, and nearly 80 million people have moderate to severe visual impairment. And cataract surgical rate in sub-Saharan Africa is very poor compared to the developed world, where they have over 6,000. And here, most countries have significantly less than 500. And yet we have a large backlog of cataract. And cataract is a disease that cuts across different socioeconomic cadres. So irrespective of your status, your race, you can develop cataract. So on this note, every ophthalmologist should be a cataract surgeon. And like every other surgical procedure, cataract is not without its likely and possible complications, even in the best of hands. So, and that's why getting acquainted and knowing the possible complications that can occur will help to take necessary precautions in order to prevent it from happening. So cataract surgery generally has evolved significantly over the past decade with the advent of modern techniques and then laser. So it has evolved from intracapsular cataract extraction to extracapsular cataract extraction. And then we have small incision cataract surgery, and then phaco emulsification that uses ultrasound energy to emulsify the nucleus. And this could be manual, could be laser assisted. But for the purpose of this discussion, I'm going to focus more on 6 and make reference to the other possible technique. So 6 is a procedure that requires a sclerocorneal tunnel to access the anterior chamber and to be able to make access to the cataract for removal. And it's supposed to be a self-sealing incision in which the external lip on the sclera is smaller, usually ranging between 5.5 to about 7, based on different literatures and different studies. And the inner lip usually shouldn't be more than 9 millimeters. And so it should self-seal unless there are complications along the way or situations whereby we can obviously see that it is not self-sealing and we may have to put some sutures. So a good way to remember some of these complications and to be systematic about it is to just think about the steps involved in the process of the surgery. And each step can have its own possible complication that can result. So if we're starting with 6 now, I would like to actually classify the complications into intraoperative and postoperative, which could come early, and some could actually be early and also come up later on. And then we have those that are obviously late complications. So for the intraoperative complications, one could sustain trauma to the superior rectus while trying to insert the bridle suture. And we need this because it helps to give good exposure. We have to work on the sclera. We need good exposure. We need globe stabilization, especially when you have patients that are not particularly cooperative. So, and trauma can be sustained to this muscle. Usually the force in the process of inserting the bridle is not enough to avulse it. So most of the time, nothing is done about the trauma. It heals, but there could be residual ptosis at the end of the day from this trauma. So buttonhole can occur while making scleral tunnel. If the dissection is too superficial, one could have a buttonhole or perforation. And sometimes if it is very, very superficial, the flap can be completely amputated. So a good way to prevent this from happening is to try and bevel the edge of the crescent knife downwards, but not too deep. And if you notice that buttonhole has occurred, it is prudent to just start the dissection from the other end so that you can go below the buttonhole and then you can continue with your surgery that way. And if you have an amputation, then that area should be sutured. You have to do another tunneling in another area, and you can go below it, and then that area should be sutured, as long as it is safe. If there's no entry into the AC. But if the dissection goes so deep and there is premature anterior chamber entry, that makes your dissection to be so close to the level of the iris, and that can predispose to early iris prolapse, and that makes the surgery cumbersome from the very beginning because you have to keep repositioning your iris, and that's constant touch of the iris. The pupil can shut down even before capsulotomy is done. So it makes the surgery more difficult. So it's one way to prevent some of these complications from happening is to actually do a very good wet lab. A good practice of wet lab, tunneling with oranges, with different materials, makes it easier when you go in for surgery. Because even skilled surgeons in the UK, like one of my consultants to tell me that he actually had a consultant at some point that still does wet lab. It sounded funny to me, but she's a skilled surgeon, but she still does wet lab from time to time. So that's a big deal. So if you And it's good to identify your weakness in your surgery. So if you know you're likely to have buttonhole perforation, do a lot of wet lab to prevent this. And next is oversized incision. It is better to have a moderate incision into the anterior chamber prior to your capsulotomy. This is because you need the AC to be well formed while you are performing, especially if you're performing a CCC, that's the continuous curvilinear capsulorhexis. It is better when your AC is well formed. If the incision is so large, after your tunnel, you make a large incision. Some do it, it works for them. But if you expand much earlier, the AC keeps shallowing. You have to use a lot of viscoelastic to form it while trying to complete your capsulorhexis. So better to use a moderate sized incision for that. And excessive bleeding can occur at any stage of the surgery. Even while raising the conjunctival flap, there could be a lot of oozing vessels. While making the tunneling, there could be oozing. And some patients are more predisposed to having a lot of bleeding this way. Some hypertensive patients that are not well controlled. Really, you don't want to even operate on a patient that has a diastolic that is more than 100 because of the risk of suprachoroidal hemorrhage and other complications. So people like that, from anecdotal observation, have been found that they bleed a lot on the table. Even while you're just in gentle handling, you need to gently handle your tissue and try to avoid the big, obvious conjunctival vessels. And if this happens, a gentle cautery will suffice. But if you don't have cautery and then the bleeding continues, it can go into, and if you make your incision into the AC, it can flow into the AC, obscure your view, can lead you to unnecessary complications at that stage. So there are also controversies about discontinuation of anticoagulants before surgery. Recent studies have found that there's really no difference between those that have anticoagulants stopped and those that did not have it stopped. If you have to stop your anticoagulant, discuss with the patient and they should let their physicians know so that you don't put the patient at risk of other health-threatening complications. Corneal epithelial abrasion can occur at any stage of the surgery and sometimes happen when we're clumsy with our instruments and handling. And usually when it's small, there's no need to treat it, to do anything. There'll be re-epithelialization, and if it's significant enough, a bandage contact lens can be used, including topical lubricants in your routine post-op medication can also help in this kind of patient. It's better appreciated under cobalt blue filter. A desciment membrane detachment. This is a very important, significant complication that can occur intraoperatively and can occur from instruments while introducing instruments into the anterior chamber. It can occur while trying to insert intraocular lens. It can occur during nucleus delivery. It can occur at different stages at any point in time, even while making the major incision into the AC. If using a keratome, if it is beveled upwards, it can brush on the endothelium, cause trauma to the endothelial cells, or it can even cause a stripping, and you can have your descent membrane stripped off at that point. So it is better to use a diamond blade. The expander is preferable to using the sharper keratome blade. So generally, precautions should be taken while handling instruments in the AC to prevent this kind of complication from happening. And when it does happen, you can have areas of corneal edema, swelling in that area, the part that is stripped, and they can also be striated. So the effect on vision post-operatively actually depends on the location of the stripped descent. If it happens peripherally, it may not affect vision. And at the completion of the surgery, if it is very significant, it can be repositioned by using air, VSS, viscoelastic. Sometimes you may need to put visco to push the descendant membrane back in place. And sometimes they may be need to use expansible gases like the sulfur hexachloride and the perfluoropropane can also be used to reposition the descendant membrane. So it's an important intraoperative complication that can affect the visual outcome. Corneal burn, also called fecal wound burn. This can happen with fecal emulsification. Usually from the ultrasound dissipates some thermal energy, which the sleeve of the fecal handpiece is supposed to help insulate and also redirect the irrigation fluid into the AC, helps to cool the tip. So usually there's a metallic tip and then there's a rubber sleeve around the handpiece. So much of the metallic tip shouldn't be exposed because that can predispose to this complication. And also leaving a very tight, if the corneal incision is too tight, it can also predispose to a fecal burn. The ideal corneal incision for fecal emulsification cataract surgery usually should be about 2.4, 2.5 to about 3.2. If your incision is too large, it defeats the purpose of a fecal sutureless surgery. And if it's too small, it can predispose to this complication. And when it does happen, prior to the burn, there's usually a milky fluid around the fecal tip. And when this is observed, it is prudent to just come out. Try to expand the wound, adjust your irrigation system, also lower the power settings before going back in so as not to have a corneal burn, which will shrink the wound edge, cause significant post-op astigmatism and wound leak and the other sequelae that comes with wound leakage. So when this happens, meticulous suturing should be done to close the wound properly at the end of the procedure. So I'll talk about iris-related complications that can occur intraoperatively. Iris prolapse can occur in isolation and can be part of the intraoperative floppy iris syndrome. So patients who are predisposed to having this iris prolapse intraop, like obese patients with short neck, they have this positive vitreous pressure that makes AC shallow, pushes the iris out. Or it's been recommended for such patients to have a reverse Trendelenburg positioning for surgery. Better when they have their head slightly raised up. Well, but also the comfort of the surgeon should also be put in place while trying to ensure this kind of positioning. So when it happens, it makes surgery more cumbersome. There's risk of trauma to the iris. You can have iatrogenic iridodialysis, iris tears, which can cause bleeding intraoperatively. So when this is noticed, particularly in obese patients, a good step is to try and loosen the external speculum. So that will at least reduce the external pressure. And if patient is not under general anesthesia, can try to encourage the patient to relax, open the other eye, if the other eye is there, and also to try not to strain, just want to reduce the positive vitreous pressure and try to maintain the anterior chamber. And so when there's damage to the iris and you have iridodialysis, if it is very small, if the tears and the damage, the trauma is small and you don't have so large area of the iris that is torn, it can still be, you don't need to necessarily suture or close it. But a significant iridodialysis up to over 90 degrees, up to 180 degrees, needs to be repaired. A Cobbler's technique has been described in the repair of iridodialysis. And when there's trauma to the iris, it can also cause post-op chronic pupillary dilation. So you have chronic traumatic mydriasis, and patient can complain of glare, complain of dysphotopsia. Sometimes you may need to do something about it. There are options of artificial iris devices. You can also do iris saccage, in which you have to, there's a surgery to reduce the size of the iris, but it is fixed, and then there's usually no possibility of a future dilation. So usually a 4 mm is the size that the iris is reduced to enable posterior segment examination. And so the iris prolapse that occurs in the setting of intraoperative floppy iris syndrome. This condition can occur with exposure to when patients have used alpha-1 antagonist. And it is important to know that just a single dose of this medication can predispose the patient to this. And so discontinuation of the drug alpha, whether selective or non-selective alpha-1 antagonist, does not, discontinuing them on those medications does not change your risk of developing IFIS. So also some antipsychotic agents, risperidone, have also been found to be implicated in intraoperative floppy iris syndrome. And this syndrome consists of a triad of billowing iris, the iris is flaccid, billowing, and then there's progressive intraoperative pupillary constriction, and there can be, which could lead to complete pupil shutdown in this kind of patient. And then there's the tendency for the iris to prolapse through surgical incision. So this triad makes up the syndrome. And a very good way to manage this is to ensure preoperative dilation with atropine. And intraoperative adrenaline can also be used for this patient. You have to use viscoelastic, the cohesive type of viscoelastic, generously for them. And also, if there's shutdown of the iris at the beginning of the surgery, you may need to put, if you have access to, if you have iris hooks, that will help. Iris hooks can be used in such circumstances. There's also the Malyugin ring that can be used, also Calabrava ring. So this can help to dilate the pupil for you to continue your surgery. So it is something that you don't anticipate it, even though you anticipate it intraoperatively, but I mean, getting the knowledge that this, you could be at risk of running into this, should be done preoperatively. So a good pre-op evaluation of your patient, you should know all the medications that your patients are, especially when you're dealing with elderly male patients. So you can anticipate this and prepare for it. Radial tears can occur during capsulotomy. And the problem with this is the fact that it can run posteriorly and cause a PC rupture. So while performing a capsulotomy, it's always helpful to have a steady hand while in the AC. And also, when it is being done, if a CCC is being carried out and one could see that the capsulotomy is running off, you can start your capsulotomy from the other end. You can leave the part that is running off. You can start from the other end and push and try to drag it inwards, so that way you can try to be in complete control of your capsulotomy. So these are pictures to just show capsulotomy and radial tears while performing a capsulotomy. So it's not only CCC that can, even while performing can open and can have radial tears. Zonular dehiscence, zonular dialysis. This is a very important intraoperative complication, and it may not be noticed. You may not see zonular dialysis preoperatively while you are preparing your patient for surgery. It can be more obvious when you are in surgery. It may be the first time you'll be noticing the zonular dialysis while on the table, and you have to take decisions on how to proceed with your surgery. You must be willing to make adjustments to your earlier plans on the type of lens you want to use, the position of your intraocular lens. So there are some conditions that predispose to this. Very hypermature cataract have been known and found to have associated zonular weakness. Also, patients that have pseudoexfoliative syndrome, patients with Marfan's, and other conditions that can predispose to zonular dehiscence. And Even zonular dehiscence occurring intraoperatively can be from overinflation of the capsular bag during hydrodissection. So it should be done gently. Hydrodissection should be done gently. You shouldn't be aggressive while doing it, so it doesn't overinflate the bag and then pull on the zonus. So the management of zonular dialysis depends on the extent of the dialysis, how many clock hours are involved in the dialysis. When you have less than 3 clock hours, you can still go ahead with your surgery. Some still go ahead with FICO, even though it has to be in a very experienced and sometimes I personally will not recommend that. But if it has to be done, you have to take all the precautions, because doing a CCC, which is very critical and which you have to do in FICO, will allow some traction and pull on the zonus. So when there's zonular dialysis, sometimes it's better to just do a can opener. If you have to do hydrodissection, it has to be very gentle. And if it's placement of your intraocular lens can be in the bag when it is less than 3 clock hours. You can put it, but it should be done with a 3-piece intra-IOL, and then the aptic should be in the direction of the defect. For example, like in this picture, the aptic should be directed towards this area where there's defect. So that way it helps to spread out, and then your lens can be central. But if you go away, if the aptic is directed away from this, it pulls it away, and then at the end of the day, you have decentered IOL, and that's if it doesn't even get worse, and then you have subluxation from it. So if it's more than 3 clock hours or less than 5 clock hours, there's the option of capsular tension ring. So in this case, you put the tension ring to give it some stability before injecting your IOL. And when it is more than 5 clock hours, it is advisable to put your IOL in the sulcus. If you have a good anterior capsule, you have good support. The sulcus generally has a larger, wider area compared to the wound incision. So, and it's usually about over 10 millimeters. So you need a lens, you need a 3-piece. You shouldn't put a single-piece lens in the sulcus. It should be a 3-piece lens with good optic area so it can be stable in the sulcus. So the management, and sometimes you may need to do a scleral fixated, especially when it's worse than 5 clock hours, and then you don't have good sulcus support. A scleral fixated or iris fixated IOL can be done where the expertise is there to do it. So these are examples of capsular tension rings that can be inserted into the bag to place your IOL. So there's a condition called lens iris diaphragm retropulsion syndrome. This occurs in highly myopic patients, previously vitrectomized eyes. And what happens, I think of it, a way to remember this, just think of the reverse of the floppy iris syndrome, because here there's marked deepening of the anterior chamber, there's posterior bowing of the iris, and then there's pupillary dilatation in this case. And it's been discussed and found from studies that lifting up the iris from the apposition it's made with the anterior capsule can help to break this block. So it's something to anticipate when a patient has a previous history of vitrectomy, and someone who has a very that is highly myopic. You may have to think about how to manage this. It is recommended and preferred that a VR surgeon carries out cataract surgery in previously vitrectomized eyes, because there's a change in the dynamics of the eye, the anterior chamber, posterior chamber, pressure balance is different, and it is best managed by a VR surgeon. So if you run into trouble, if there's any complication, they can manage that, since there is even a history of previous retina surgery. Cyclodialysis occurs when there is a separation of the ciliary body from its attachment to the scleral spur, usually the longitudinal fiber of the ciliary body. And when this happens, it's better appreciated on gonioscopy, is well appreciated on gonioscopy. That's when you'll be able to see the cyclodialysis cleft. So it can be mild, it can be moderate, it can be severe. If it's a little dialysis and then there's no significant hypotony with it, it might heal by itself, and patients will be monitored closely for that. And if it's a very significant cyclodialysis cleft that is associated with severe leakage, because the cleft connects the anterior chamber to the suprachoroidal space, and then you have a lot of digression, is fluid, the aqueous passes out through the cleft, and you can have hypotony, and all the sequelae of hypotony. You can have choroidal effusion, you can have hypotony maculopathy just from that. So when it is very significant, it should be repaired. It should be repaired. It can be repaired transscleral, and there's also the use of laser. Argon laser can be applied to the cleft if it is moderate or mild, and that will cause fibrosis and then close up the cleft. Also, transscleral diatemy, transscleral cryotherapy have also been discussed in management of this condition. But there should be high index of suspicion when you have hypotony that can be accounted for by any other thing, no external wound leak, and then this should be suspected. So that's about the intraoperative complications. I'll start discussing the early post-op complication. So very commonly, subconjunctival hemorrhage can be mild and can be very severe, that the patient can have bloodshot eyes following surgery. Usually as a trainee cataract surgeon, we've been advised to focus more on the visual outcome and not the external appearance of the eye after surgery. But with time, as you become more comfortable with your surgery, you don't want to finish your surgery and have everywhere all red, bloody. You are now more concerned about the cosmetic appearance of your patient postoperatively as you advance. So there could be, this usually resolves within weeks, to resolve weeks after surgery, and may not require any special treatment, just the routine post-op medication. So there could be shallow AC from wound leak. This can occur following ECC, it can occur following 6 if your tunnel is not self-sealing. It can also occur following fecal. So, and CDELS tests can be done to be able to identify where the leak is from and the extent of the leak, how significant it is. And if the AC is shallow, the extent of shallow AC can also help to, will also determine your approach in management. If the AC is so shallow, you have lenticular, you have IOL, endothelial touch, that's an indication to go back into theater and reform the AC. For mild shallowing of AC, low pressure, one could adjust the steroid dosage, reducing the steroid. It could be managed in a similar fashion to post-trabecular wound leak. So you can reduce the frequency of steroids to allow some wound healing. You want to give patients aqueous suppressants so that more aqueous is not produced and passing. As long as aqueous is passing out through the wound, there is less likely to heal. And then also bandage contact lens can be used. And if all this will not suffice, we need to take the patient back in to put a suture and reform the anterior chamber. Corneal edema is a very common post-op complication, which can be associated with IOP. Not necessarily, sometimes you have edema without raised intraocular pressure. And there are a number of factors that are associated with development of corneal edema. One important factor is instrumentation, trauma to the endothelium during surgery. And so it's important to, as much as possible, coat the endothelium with dispersive viscoelastic. or the soft gel technique. So that will help to protect the endothelium against trauma. Also, preservative in intraocular fluids and also chemicals on the instrument used. If the chemicals are not well washed, the chemical agent used to clean instruments can also cause toxic damage to endothelial cells. And corneal edema post-op is usually as a result of acute endothelial dysfunction or decompensation. And when it is due to raised intraocular pressure, performing a paracentesis may help to clear, but sometimes even performing paracentesis will not clear it. In patients who have predisposing conditions like Fuchs endothelial dystrophy with low endothelial cell count, those kind of patients may not improve with just doing a paracentesis. You may need to place some of them on hypotonic saline postoperatively. You may need to give them and also give pressure lowering drops. Patients who are previously glaucomatous and who are on glaucoma medication can also develop corneal edema postoperatively. Striatic keratopathy, the mechanism is also similar from instrumentation. Also, when your AC shallows a lot, when you find it difficult to maintain your anterior chamber while doing irrigation and aspiration, if the AC shallows, reforms, the repetitive flattening of the AC can, and then also while pulling out, while expelling the nucleus, if the cornea is not well coated with viscoelastic, can predispose to this. And if the stria is mild, a routine steroid will help to clear it within weeks and clears much faster. It clears faster and recovery is better in younger patients compared to elderly patients. So IFEMA can result from trauma to the iris, as mentioned earlier. And the degree of IFEMA affects the management, what you do to manage it. So immediate post-op period with full chamber IFEMA, you have to go back to do a washout, or over 50%, you have to do a washout. When it's less than 30%, less than a third of the anterior chamber space, and the intraocular pressure is not so bad, the patient, it can get absorbed by itself. You just need to monitor the patient. You want to see them within a week. You want to check their pressure. You want to see how it's clearing. And if it's not clearing and there's associated with intraocular pressure, it may just be good to do a washout of the anterior chamber. So you can have lens fragments, retained lens fragments. If it is cortex, it's better than when it's nucleus, because it's been found that the nuclear lens matter is more likely to give raised intraocular pressure compared to the cortical remnants. And also the location of the lens fragments will also affect the management. If it's within the pupillary area, is blocking the patient's view, it's just better to go in and wash it out. But if it's peripheral, it's small, it can get absorbed over time. So I'm going to talk about toxic anterior segment syndrome. Toxic anterior segment syndrome is an acute sterile inflammation that is limited to the anterior segment. It usually occurs within hours, because sometimes when you do cataract surgery, you remove the pad. Not everyone removes pad the next day. So, and it's something that can be seen within hours of the surgery, which is quite different from acute endophthalmitis that is said to occur within days, can occur within 2 to 7 days after surgery. So in toxic anterior segment syndrome, the patient can present with, there could be pain, but the pain is usually less compared to endophthalmitis. It could be anterior chamber cells, there could be fibrinous exudates. The pupils can be mid-dilated and unreactive. And the the pathogenesis of these has been found to be related to the agents, preservatives in intraocular fluid, and also chemicals. Povidone, chlorhexidine has also been implicated. You know, when used to clean the eye, if it seeps into the AC, it can also predispose to this condition. And the mainstay of management is steroid, intensive topical steroid, and that can be supplemented with oral steroids. So, and there is usually no vitritis. Vitritis is the hallmark of endophthalmitis. You don't have vitritis in toxic anterior segment syndrome. And usually with steroid, it should resolve. There could also be hypopyon, and then the redness, the conjunctiva, the redness, the beefy redness appearance is more typical for acute endophthalmitis, unlike compared to toxic anterior segment syndrome. So another post-op complication is pupillary block. Pupillary block can occur with anterior chamber intraocular lens. It can occur with posterior chamber intraocular lens, particularly in the setting of zonular dehiscence, where there's slight subluxation of the lens can cause a pupil block. You can also have it even when there's no lens implantation done, because there are times that the primary surgery is to leave the patient aphakic. People who are highly myopia and the IOL power is minus 0.5. So then you just leave this kind of patient aphakic. So you can have pupil block under such three circumstances. And when it happens, there's usually anterior bulging of the iris. You can have iris bombay, and it clogs and blocks the anterior chamber angle. It's raised intraocular pressure, and this can be relieved with a PI. And usually when you put an anterior chamber intraocular lens, there should be a PI. It's almost criminal to put an ACIO without putting a peripheral iridectomy. So if this is blocked, that can also result in a pupillary block. So a JAG laser to open up the PI, or to create a laser to do an iridotomy, can help to release the block and resolve this. In aqueous misdirection, there's a block. However, the AC is flat both peripherally and centrally, which is illustrated in this schematic diagram. So what you have in aqueous misdirection, that is also called ciliary block, so known as neovascular glaucoma, is there's anterior displacement of the iris processes, the lens, iris, diaphragm, anterior displacement. And when this happens, the normal flow of aqueous from posterior chamber to the anterior chamber is altered. So you have redirection posteriorly into the vitreous. And so there is also closure of the anterior chamber angle, and then there's fluid diffuses into corneal stroma. You can have corneal edema, and then there's increased posterior pressure. So when this happens, one could start a medical treatment, giving aqueous suppressant, but miotics should be avoided in this kind of situation. Patient can benefit from cycloplegics, and drugs like beta blockers can be used in these settings. And it is also one way to disrupt this process is to perform a YAG capsulotomy and alter the anterior vitreous face. So when there's disruption of the anterior vitreous face, this allows the fluid to flow back. If this does not help it, Chandler's procedure can be done, which is aspiration of vitreous out through a sclerotomy port, or a pars plana vitrectomy can be done ultimately to relieve this. So we could also have induced astigmatism from sutures and ECCE, even from 6, because if while before the tunnel, usually there's cautery of the scleral bed. If that is done too aggressively, it can also cause astigmatism. You can have refractive surprise when you have poor visual outcome from high refractive error. and that can be biometric, that can be from biometric error. And sometimes when it is very significant, they may be need to do IOL exchange. In such patients, sometimes a piggy bank IOL has been talked about to manage this, or patient could have a refractive surgery done. So this picture shows capsular block syndrome. Capsular block syndrome, also known as capsular bag distension syndrome. It can happen early, within few weeks of surgery, and it can happen late, several years after surgery. When it happens early, it could be because viscoelastic is trapped between the IOL and then the posterior capsule. And so a way to disrupt this is if the edge of the anterior capsule is visible, just like in this picture, a laser towards to the peripheral part of the anterior capsule can be done in order to release this block, because the IOL is pushed against the anterior capsule, and then there's the iris anterior capsule apposition in this block. So when it occurs later in life, is due to accumulation of turbid fluid behind the IOL. So in this case too, an Nd:YAG anterior hyaloidotomy can also be done to disrupt the fluid and make it go posteriorly to free this block. And this relieves the myopic shift that the patient would have suffered and reduce vision also from this. So I will discuss IOL-related complications. But before that, I will make mention of the vitreocorneal touch vitreous weak syndrome. So in vitreous weak syndrome, you have vitreous at the wound edge. So this complication comes when you have a PC rent, obviously, or a very significant zonular dialysis with vitreous prolapse. And because of the presence of the wick, there's a connection between the posterior cavity and the posterior segment, anterior segment. It can result in recurrent inflammation in such patients. And sometimes the wick is adherent to the endothelium. And when it is visible, when it is seen clearly, a laser can be applied to it, and that may help to relieve the inflammation, and also because this can predispose to cystoid macular edema, that has been found to be helpful in reducing that too. So the intraocular lens-related complications that can occur postoperatively, you can have lens decentration from pores zonals can occur while the IOL is in the sulcus. You can also have dislocation of the IOL. This could be intracapsular, this could be extracapsular. The obvious cause of the intracapsular cause usually when there's zonal weakness. So the bag tilts downwards or moves downward or upwards. And when it is extracapsular, the IOL is dislocating or is dislocated out of the bag. That happens when you have an excessive, exaggerated, large, oversized capsulorrhexy, capsulotomy. So usually the capsulotomy should be about 5.5 mm. When it is too small, it can predispose to having anterior capsule fibrosis, phimosis. And when it is too large, it can predispose to this condition where the IOL gets dislocated out of the bag. So it is better to try and make the capsulotomy just appropriate to avoid this complication. And when this happens, the IOL, the actin can rub on the iris, cause recurrent inflammation and continuous cycle of pigment dispersion, increased intraocular pressure. And this itself can predispose to having corneal decompensation. You can have a bullous keratopathy from this. The sunset syndrome is described based on this appearance that is typical in congenital hydrocephalus. In this picture, we can see the appearance of the child's eye looking downwards, and then I put the IOL, subluxated IOL beside it. So it's this picture that gives the name sunset syndrome. So if this gives significant diplopia, dysphotopsia, there may be need to do lens repositioning for this patient, or do a scleral fixation, iris fixation. Iris fixation IOL is not without its own complication, because if it keeps rubbing, it can predispose, rubbing on the surface of the
We lost her. 1 minute, please.
To improve the patient's vision. Bullous keratopathy can result from chronic corneal edema and is characterized by bully, there's pain, redness, photophobia, tearing. This can be managed with different temporary measures, drops using hypertonic saline, and maybe you need to do phototherapeutic keratoplasty, whether deep or superficial. Even cross-linkage has been used to cause temporary relief, but ultimately patient may require penetrating keratopathy for this. So patient can have iris atrophy, can have pupillary capture. These are pictures showing PCO. Before and after capsulotomy. There are different techniques. There could be the cruciate capsulotomy, the sarcomania one,
Abiola,
and then yes.
we can't see your slides.
Again,
Kindly reshare it.
okay. Okay. Can you see it now?
Yes, please. Thank you.
Can you see my slides?
Yes, please. We can see your slides now.
Can you see it?
Yes, yes.
Okay. Okay, so I just want to rush through it so we can have questions. Okay, this is the last part. Uveitis erythema glaucoma syndrome, the Brown-McLean syndrome, that's a rare complication. The last two complications are rare complications, and the uveitis erythema glaucoma syndrome is a chronic complication and usually associated with anterior chamber intraocular lens placement and can lead to corneal decompensation, and eventually there may be need to explant the lens to save or salvage the cornea. Brown-McLean syndrome is when you have peripheral corneal edema. It's rare. It's a diagnosis of exclusion, and it's the central area of the cornea is clear in this disease. Epithelial downgrowth, fibrous ingrowth. In the epithelial downgrowth, you have epithelial cells migrating and lining intraocular structures like the endothelium, the iris surface, even the angles. When it is fibrous ingrowth, it's not just epithelial cells, it's a fibrovascular tissue. And this has been found to cause intractable secondary angle closure glaucoma. And such patients may eventually require a tube implant to lower and control intraocular pressure. Okay. Thank you. Spent almost all the time.
Thank you, Dr. Abiola, for this beautiful presentation. You really tried to cover most of the anterior segment complications. I also went ahead to tell us some of the things that we can do to save the situation when some of these things happen. So now we're going to pause to entertain comments, questions. For now, I can't seem to see any question on the chat box, but somebody gave a contribution, Dr. Umar. So he said one can avoid shallow anterior chamber in course of surgery by performing CCC, that's a continuous curvilinear capsulorhexis, through a side port rather than through the main wound. He also added that following the use of SF6, viscoelastic or perfluoropropane, in addressing descendant membrane, when membrane is stripped. So regular post-op intraocular pressure check becomes paramount, especially during the immediate post-op periods. And then thank you for the presentation. Thank you, Dr. Umar, for that beautiful contribution.
Thank you very much.
Do we have questions? Please, you can signify if you have any question, and I'll call you to ask, please. I can't see any. So that means the presentation
I can see
was
a question here.
okay. All right. You can take it, please.
I can see a question here. Please, can
Okay,
you
yes.
throw more light on difference between epithelial downgrowth and fibrous ingrowth? Okay. So it could be epithelial ingrowth too. You can, it's also called epithelial ingrowth or downgrowth, and fibrous ingrowth or downgrowth. So what happens is in epithelial, it is epithelial cells that migrate inward into the intraocular space and lines the surface of the endothelium, surface of the iris, giving it an irregular contour, and also line the angles. But in the case of fibrous, it is fibrovascular tissue, not just epithelial cells. So it is worse. It is worse than just the epithelial ingrowth. Have I answered your question, please?
Yes, you have. She also asked another question on.
Hello?
Hello, Dr. Biola, can you hear me?
Okay, I couldn't, but now I can.
Okay. She also asked another question. The mechanism of action,
Okay.
how tamsulosin causes floppy iris. Floppy iris.
The exact mechanism is not clear. Yeah. So it's from studies and from observation that these drugs have been associated with intraoperative floppy iris syndrome. But if there's any more explanation on that, I would like to know. Because antipsychotics cause floppy iris syndrome, and they don't act by blocking of alpha antagonist.
Yeah, you're right. The mechanism is not actually well stated. But because it has high affinity for adrenergic receptor, which is a dominant receptor in the iris, so that can, but the exact mechanism is not well understood. Somebody else has a question, Dr. Mariam Fashola. Dr. Abiola, are you with me?
Okay, please, can you, I'm not seeing everything clearly. I'm seeing some.
Okay. Let me read out this one. This one says, thank you for your
Can you
presentation.
help me? Yes, can you help me?
Yes. Can you please re-explain? Okay, sunset IOL. That she missed the explanation on sunset IOL. That can you please re-explain? Apologies for taking you back.
Okay, to see my slide so that I can show it and explain that.
Yes, your slides are visible.
Okay. Okay. So sunset syndrome occurs with intraocular lens placement usually in the sulcus. That's when you have this kind of condition occurring. And so there's inferior subluxation. The inferior uptake can pass through a weak zonus and subluxates inferiorly and gives it this appearance, like a sunset kind of appearance. So it's just a descriptive, a good description of what is happening with the eye because of this sunset eyes I seen in hydrocephalus. That's where that eponym came from.
Okay, thank you. So there's another question here. Okay. That I should throw more light on how capsular block occurs. The one you explained earlier, that you should throw more light on it. How does it occur?
Okay, so the capsular block can occur early when you have viscoelastic, particularly the cohesive type of viscoelastic, when it is trapped between, normally you put visco to help fill your bag before you introduce your IOL. So if it is not well aspirated following surgery, and you have some visco trapped between the posterior capsule and the IOL. It can cause this block because it could push the IOL forward, opposite to the anterior capsule, and then there's opposition of the iris to the anterior capsule. So that can cause the block, the syndrome.
Okay,
So, but
thank
when
you.
it occurs late, it may be sipping of fluid, gradual sipping of fluid through the, it could go in through the capsule, through the anterior, because usually the lens, the capsule is intact when this occur. So somehow some fluid find a way of getting to the back of the IOL, and the fluid is described as turbid fluid accumulate over time. It's possible that this fluid accumulated even from the period of the surgery, but did not become apparent until much later. So that's the description for the late presentation of the capsular bag distension syndrome. So to manage that, there has to be a way, the fluid has to come out somehow. So doing a capsulotomy, a laser capsulotomy, and such that the fluid can escape posteriorly, can help to relieve that.
Okay,
I hope that answers the question. I hope.
thank you. So somebody asked, for pupillary block, when can you do iridectomy and when do you do iridotomy?
For pupillary block, you can do it immediate post-op.
Okay, the person wants to know,
Hello?
is there a time, is there a particular preference or when you do iridectomy or when you do iridotomy?
Okay, iridectomy is usually done intra-op. For example, if you're putting anterior chamber intraocular lens, you do a peripheral iridectomy. But iridotomy is achieved with laser. So the patient is not on the table, you're seeing the patient post-op. You may be seeing it at 1 week post-op, you may be seeing the patient at some days post-op, because it may not even, you may not see it, they may not be apparent in the immediate post-op period. But when the patient comes, there's a block, the pressure is so high, a patient that is not previously a known glaucoma patient, and then you can obviously see that there's a block, there's bombing. You want to do a PI, that's iridotomy, laser iridotomy.
Okay. And someone
So
said, can you discuss Brown-McCann syndrome? No, you mentioned Brown-McCann syndrome.
yes,
Can you
yes.
discuss it again?
Okay. So Brown-McCann syndrome is a rare entity that has been described in patients who have had cataract surgery and has been found to occur even several years after the surgery. And it is described and found to be associated with peripheral corneal edema, usually between 1 and 2 millimeters on at the peripheral end of the cornea. That is not associated with neovascularization. And the central part of the cornea is clear in this syndrome. And also it is found to have pigment cells deposited in these areas where you have the edema. So it's the etiology of the syndrome is unknown. It has been described in a normal, it's been described more in intracapsular cataract extraction, but it's also been described in ECC and rarely in FACO, but it's also been described with those techniques too. So rarely it can progress to complete corneal edema and can cause bullous keratopathy. And sometimes it resolves on its own. So it's a very rare complication of cataract surgery. And when there's edema, you have to exclude all other possible causes before thinking or talking about Brown-McLean. It shouldn't come up in the discussion. It should be somewhere down the line when you're discussing anterior segment complications of cataract surgery. Because I have never seen any, and a lot of my senior consultants have never seen any. So, but it is something to know.
All right, thank you, Dr. Abiola. Somebody wants you to mention the name of the procedure. Aspiration of vitreous, when you were talking about aqueous
Chandler's.
microretina.
Chandler's procedure. Chandler's. It was described by Chandler.
All right.
Chandler.
Okay.
Chandler's procedure. Chandler's technique. Yeah. You know the Chandler's in ICE, iridocorneal endothelial dystrophy. You know there's the Chandler's part of the triad. So Chandler's procedure. Yes.
All right. Thank you very much, Dr. Abiola. It's been a wonderful presentation. We enjoyed the presentation and also the person. Thank you very much. So I think there are no more questions. I can't seem to see any more. So thank you all for being there too, for making it this morning to join this presentation. I hope you all gained and to go a long way to improve our practice and also ease some of the difficulty we have in the residency program. Thank you very much, everyone. So let's make it a date next fortnight when we'll be having another presentation. Thank you so much. Enjoy the rest of your weekend. Bye-bye.